Welcome to today's webinar session by Zambia Paediatric Association of Zambia. And moderating this session is Dr. Kozia Ziambo, the Publications and Research Chairperson for the association. We have a very important topic that we'll be looking at this afternoon, and I do hope everybody's quite ready and eager to get involved this afternoon. So today we have one of our neurologists, a pediatric neurologist, and we also have our other experts that will just want to share some thoughts around autism. And so we have Dr. Nkole, who will start us off. Then I'll be followed by Alice, and she's done a lot of work. She will be able to introduce herself, but has done a lot of work in this space. And then also we have Jessica, who also would like to share some of her experiences. And then afterwards, we'll have a question and answer session where everybody will be able to participate. So thank you very much, everybody, for joining in. So I will invite Dr. Kafula. Could you please go ahead and begin your session?
Thank you so much, Kozia. So my name is Kafula Nkole. I am a pediatrician, pediatric neurologist based at the University Teaching Hospital. Very passionate about autism work as well as other neurodevelopmental disorders. So we thought that we should talk about what happens after you have been given the diagnosis of autism, because many parents and sometimes teachers and families really struggle with what to do, where to go. So we thought that we could share some of that knowledge with everybody here joined. So I will focus more on getting the diagnosis, and I will speak a little bit about what happens after that diagnosis, and then my co-speakers, Alice and Jessica, will talk about the nitty-gritties of managing behavior and communication. All right, so just to give an overview of what autism is. So this really is a condition that presents with persistent deficits or limitations in communication and social interaction, as well as having the presence of restricted repetitive patterns of behavior. So up until about 2015, this is now the unifying term for previous subtypes. So in the past, there was autistic disorder, and then there was Asperger's syndrome. So thereafter, using the DSM-5, we only have one umbrella term, autism spectrum disorder. So to talk a little bit about what the deficits mean or what they are. So when we talk about deficits in communication and social interaction, you're looking at how individuals with autism will respond to social environments. So how they respond to cues, how they have problems with communication, so how they use the nonverbal communication in terms of behaviors. So pointing, issues of eye contact, issues of interacting with other children. The other part of the social interaction and communication is the way that they develop relationships. So are they able to make friends? Are they able to keep their friendships? Are they able to have relationships and friendships appropriate for their developmental level? When we talk about restrictive patterns of behavior and interest, really we're talking about repetitive patterns of either speech or motor movements or the use of objects. So I'll give an example of if you are saying hello to someone, the normal response that we expect is, oh, hello, how are you? But there's some individuals who are on the spectrum that will respond with just the same hello, hello. So they parrot what is being told to them because they can't really have a normal back and forth conversation. And then there are certain repetitive movements of the body called motor stereotypies that they might have repetitive movements of the hands, they might have hand flapping, they may be spinning, they may be swaying from one side. So those are what we call repetitive movements. Other things are these ritualistic patterns, the way they play, how they play with objects. So sometimes they will line up toys, color code them, different colors, the yellow ones, the red ones, the blue ones, or in terms of size or in terms of shape. So they sometimes have these ritualistic ways in which they play, or they have certain behaviors and they're so resistant to changing these ritualistic patterns. And then there's the highly restricted fixated interests, meaning they're very fixated on wanting things done the same way. I'll talk a little bit about the hyper and hyperreactivity to sensory stimuli. So those that are sensory seekers, meaning they're hypersensitive, so sometimes they like deep touch, so hugs. Sometimes they want to just put their head on a cold surface because they like how that surface feels. And then there are those that would have sensory overload. So if it is to noise, for example, they might cover their ears, or they don't like the way certain textures feel. They don't like certain textures of their clothes. So for somebody to have a diagnosis of autism, they have to have the deficits in communication, social interaction, additionally, the presence of restrictive, repetitive patterns of behavior. So this is called a spectrum because really there is a variability in presentation. Also, people or individuals with autism have different abilities. And this diagnosis is very individualized. And sometimes, most often times, it doesn't just take into account the deficits that this person has, but also highlights their strengths. And then also, usually each child has their own individualized management plan that should be made for that particular child. So in terms of screening and diagnosis, it goes two ways. So either you have a parent who has concerns about their child's development, whether their teacher brought it up or a neighbor, or sometimes it's just inherently the parents that come in because my child sometimes is lonely or they have communication difficulties, so speech delay, or they are not able to have, a normal back and forth conversation. Then there is the other aspect where we pick up children that are coming in for regular routine developmental assessment, or they're coming in for their well baby checks. And when we do the developmental surveillance, we notice that there are some milestones that have not been met, or there are some behaviors that you observe in this child who has come in for their routine well baby check. And ideally, the American Academy of Pediatrics recommends that we should be doing developmental screening and monitoring at the ages of 12, 18, and 24 months, and particularly for autism at the ages of 18 and 24 months. So the screening process and the diagnosis takes into account the history, a very thorough history, look at the examination, and we really emphasize this issue of a multi-specialist assessment because children with autism will have various ways in which they are affected and in which they present. So they'll present with very different symptoms. Most often than not, you need a parent report. And then there are certain times that you would need a teacher's report because this patient or this child who has these difficulties in these areas, these difficulties should be present across multiple contexts. So if they're in school, they should be present in the school and then at home, and when you see them as well in your clinic or at the hospital. So when we're doing the evaluation, the first thing is we really want to determine, does this child fit the diagnostic criteria of what autism is? What is the level of function and the neurodevelopmental profile for this particular child? Am I dealing with autism? Am I dealing with autism and another condition? Or am I dealing with another condition that is not autism? So a few early warning signs of autism that usually the parents would come with. So things like poor eye contact or limited eye contact. So these children or individuals are unable to share their gaze with other individuals in the household. So difficulties with joint attention, so how they play or interact with other children. There are some children that will appear to be uninterested in their surroundings. Every time we call his name, he doesn't respond. So half the time, they're worried really that their child doesn't hear. And then the issue of nonverbal communication. So this issue of pointing, waving, nodding, and use of nonverbal communication. The other things that really bring parents in are the communication difficulties. So children may either present with delayed speech, where they have not spoken, but then there are also certain children that will attain their speech and communication milestones that tend to regress in that particular domain of development around the age of 2 to 3. So there's several screening tools that are available. I will not go into this. So it just depends on the age of the child and also the person that is using the screening tools. So commonly in our environment, we will use the MCAT. We also use the ages and stages questionnaire. So it just depends on the individual who is doing the screening at that time. So for the diagnosis, I've spoken about the DSM-5 criteria, which really means that this particular child or individual should have impairments or limitations in social communication and interaction, as well as the presence of restricted repetitive patterns of behavior. And then the severity of autism will be based on the social communication impairments, as well as the restricted repetitive patterns of behavior. There are other tools, diagnostic tools that are used to assess children who have autism. So there's the ADI-R, which is Autism Diagnostic Interview Revised, and also the ADOS. So all these tools were formulated from basically the DSM-5, and they're very, very similar. It's just that they're semi-structured, they're observational, and you score a child. And so depending on where you go, they will use different assessment tools in terms of making the diagnosis. There is also the aspect of the functional severity levels of autism based on the social interactions and the presence of the repetitive patterns of behavior. And then also depending on how much support an individual requires. So these levels are categorized as level 1, level 2, level 3, denoting mild, moderate to severe. Again, after the diagnosis has been made, the next step that we usually do is to assess the functional levels and the severity of the autism spectrum disorder. So what do we have to do as doctors? What is our role really? Ours is to encourage the developmental screening and monitoring. Every child who comes in for well baby checks, ask the parents, are you happy with their development? Do you have concerns about this child's development? The other thing is the high index of suspicion. So even if a child comes in for a tonsillitis, for example, and you notice that this child has repetitive patterns of behavior, or they have communication difficulties, that high index of suspicion will lead to an early diagnosis and ultimately early intervention for this particular child that has presented to your level of care. The other thing is that really we need to coordinate the individual's care. There are so many specialists that are involved in taking care of a child or an individual with autism. It goes beyond the doctor. So we're really managing the child's needs and also making sure that if they have comorbid conditions, GI problems, or sleep problems, or they have other psychiatric comorbidities, you are the one who's coordinating the care. Additionally, we're excluding other diagnoses with autism phenotype. And very importantly is, I think Alice and Jessica will speak to this, but it just goes speech and language, communication, occupational therapy, developmental, and also vision, hearing, and lead testing. So in terms of management, there really isn't a cure for autism. Our goal of management is, can we maximize the functioning? Can we move this child towards independence and ultimately improving the quality of life? So the management of autism really focuses on the behavioral and communication and educational interventions that target the core symptoms. So because we won't have two children presenting very similarly, they will have, same diagnosis, but different symptoms. These interventions have to be targeted to a particular child. So medication usually is used as an adjunct to the behavioral and educational interventions. So usually to address other medical or psychiatric comorbidities. There are times when children are very hyperactive and, parents are overwhelmed with the behavior. And the first thing that they want really is just medication. So we have to balance the need for medication and making sure that this child is getting the behavioral and educational interventions that they require. So I won't go too much into detail with the actual drugs, but just to mention that these are some of the common comorbid conditions that children or individuals with autism will have, like hyperactivity, ADHD, aggression, severe anxiety, moods. Sleep is also a big issue, because if your child is not sleeping, it means the whole household is not sleeping. And it really disturbs the rhythm of the household and also of the child. So these are just some of the conditions in which medications are indicated. In terms of management, several approaches, and I think Alice and Jessica will go into detail on the different approaches, but these range from behavioral approaches to educational approaches. So this really just speaks to the fact that each child, the needs will be different, and their therapies or approaches that will be employed will be very different for each particular child. So what does it look like to get an autism diagnosis in Zambia? So it's very different. It depends on where you are in the country, because obviously all this multi-specialist care that we're talking about is not available in a lot of the centers across the country. But generally, you would be seen by a general medical officer, a GRIMO, or any doctor, a psychologist, a teacher, and this particular individual will be referred to the doctors who might be a pediatrician, and then if you can, a pediatric neurologist. And once they do the initial evaluation, then they would request for additional evaluation, so hearing assessment, speech and language, occupational therapists, and sometimes educational psychologists. After we do the additional evaluation, then we will request that you start seeing either therapists or you go into school. But the truth of the matter is that there's a critical shortage, both in the education sector and also when it comes to the actual specialists that are supposed to be offering these therapy sessions. So what can we do about it? We know what the gap is. So we really need to optimize the issue of institutional collaboration. If we can't offer it all, we need to figure out how we're going to collaborate with either other centers, other individuals that have that service. And additionally, we need to capacity build. And in capacity building, we need more speech therapists, occupational therapists. Alice and I are part of a team that is doing some work in Ndola teaching and training physiotherapists and doctors and special education teachers on the diagnosis and management of autism. But away from that is we really need to we need to task shift and think about training the parents. So caregiver skills training, because these are the individuals that live with this child in the household. So what they're taught and what they are teaching their child is a lifelong skill. And this has to be it's a continuous process. So we really have to empower this particular cohort of individuals. So you have the diagnosis of autism. In most cases, it is a lifelong condition. There are improvements in the core symptoms depending on when the diagnosis was made and what interventions have been put in place. And there are several factors that have been associated with the favorable outcome, including those that have higher cognitive abilities and the severity of the autism. But the take-home message is that the earlier we make the diagnosis with the early intervention, that should improve the long-term outcome. So to conclude, autism can affect any individual, doesn't matter what race you are. What we do know is that the causes, risk factors are still being explored in detail. The other thing is that we are seeing more and more cases of autism, not just in Zambia, but also globally. We also know that the earlier you diagnose the condition, and early intervention is preferable, and that multiple specialist involvement is really critical in the management of children with autism. Additionally, we all need to continue advocating for more services for individuals with autism in Zambia, so both educational and health services. So that is, thank you.
Thank you so much, Dr. Kafula. That was very, very informative session, talking about the symptoms, how you identify the flags, the red flags that you need to look out for that parents come with, and then also just the approach, the management. Thank you very much. So we move on to the next session. We'll have Alice come in and talk about the behavioral component and what is done around that.
Thank you very much. My name is Alice Tenjiwe Kabwe. I'm a child development and disability inclusion specialist. Very excited to be here and very happy to hear about the emphasis that VA has on supporting families. So my presentation will really cover looking at the behavioral approach of how we can support social emotional development and really targeting the importance of supporting families, and then I'll dive deeper into specific strategies. And so supporting families, as Dr. Nkole has already mentioned, families are really the first home for encouraging social emotional development. And I just wanted to share this reframe because in the larger disability movement, we know there has been a shift in looking at the medical model to the social model when it comes to interventions. And then within the autism shift, within the autism community, there's a movement into neurodiversity, which really looks at highlighting that brain differences are part of normal human variability. And so if we take that neurodiversity lens, how we talk to parents, how we talk to individuals with autism can be more positive. So using phrases like autism is a different way of functioning, and really just trying to highlight that this is normal variability. It's just your brain is functioning differently, and that's also normal. One other key aspect of supporting families I'd really like to highlight is about encouraging connection. There are these myths because, there's some presentations where a child may look like they are in their own world. And so there are these myths and misconceptions we have that children or people with autism do not like to socialize or they do not have emotions. And that's false. So I think really encouraging parents to maintain connection. People with autism do have emotions. They do like to socialize. They just might show their emotions in a different way. So making sure that that's highlighted. And then the other key part of supporting families is really just remembering that families can be going through quite a difficult time, and they can be stressed and they can be overwhelmed. So really making sure that our interactions with families are also taking care of their individual well-being. And then lastly, for families, encouraging families to also find value in their child's strengths, just finding an appreciation for their child, so they're not feeling so negative. Okay, now we can move on to kind of the meat of things. So when we're talking about behavior, we'll kind of go through a bit of just some basics in general behavior management from an applied behavior analysis approach. So behavior is really anything that we say or do. And there's what's called a dead man's test. If a dead man can do it, then that's not behavior, which is everything. So from my lens, behavior is not something that's good or bad. We have helpful behavior and maybe unhelpful behavior, and it really depends entirely on the context and the situation, what's going on. And our goal when we're intervening in behavior is not to necessarily like eliminate or stop. It's sometimes to integrate a more helpful behavior, a more helpful, appropriate way of communicating in that context. And for me, I really like to think about, if there's one thing you take away from my presentation, it's really trying to think about getting curious and trying to ask yourself what could be underneath this behavior. And that's something that parents as well can do, just trying to unearth what is the function. So the 4 steps we look at when we're thinking of behavioral interventions are: 1, identifying the unhelpful behavior, trying to understand what is underneath that behavior, what the function is, how we can help. Then the next step is help. So integrating some type of substitute behavior experience, and then creating a plan around that. So for behavior, identifying an unhelpful behavior, observation is really key here. Spending time observing the child, playing with them, trying to explore what that behavior may look like. For sensory stimulating behavior, Dr. Nkole highlighted, being able to watch that child, how they behave before, during, or after a particular sensory seeking experience, to help you understand the child a bit more and the different behaviors when it occurs. Key thing about what an unhelpful behavior is that it has to be a challenge for that individual, not something that me as somebody who's there is triggered by, but what exactly is it? Is this harmful to that individual or others? Is it impacting their ability to learn, play, and engage? Because there's sometimes you could think it's a problem, but it may not actually be a problem for that individual in that context. So now that we've identified, we found this unhelpful behavior, now the next step is to understand what is underneath that behavior. Why do we think that behavior is happening? All behavior has a function. You know, if I know screaming and ShopRite means that mom will give me a sweet, then I'll scream every time I go to ShopRite. Our past experiences shape our behavior. So the behavior that we have is reinforced by previous experiences that happened as a result from following that behavior. And the 4 functions of behavior are access to attention. So attention from a person, a parent maybe, a teacher, access to a toy or an item. I want this toy, I want that sweet on ShopRite. Escaping or avoidance. I really don't want to do this work right now, so I'm going to hide under the table. I'm going to put my head down. And then this automatic sensory stimulation. And the automatic sensory stimulation really serves 2 purposes, and that's to increase some type of sensory input in a way that an individual may be unable to receive in other ways. And it also helps to potentially soothe a sensory input that might be overwhelming. So it's really something that feels good for someone's internal state. For example, when you have an itch and you scratch it, so like that itch feeling is more an internal state that you're feeling. And this, what's called the ABCs of behavior from an ABA approach, is I find quite a helpful way to think about trying to understand what the function of a behavior could be. Just to note, it says consequence here, but it's not a negative thing. It's really just what happens after. So the first part we have is the antecedent, which is what happens immediately before the behavior occurs. The behavior is the one that we're actually talking about, that you've identified as unhelpful. And then the consequence is what happens immediately after that behavior. And sometimes, depending on the outcome of that consequence, what happens immediately after, it reinforces the cycle to continue again. And so one quick example here, we have, you know, Musonda's mother is talking to her sister. So Musonda starts whining. This is the behavior that we're talking about. And immediately after Musonda starts whining, Musonda's mother stops talking and picks up Musonda. So that's Musonda's, the function of whining seems to be because Musonda wants attention from her mother. I have a few other examples, but I'll skip and do this one on the sensory example. So another example here, oh, that's escape. So an example for sensory stimulation is Lisa walks into church with her mother. Lisa covers her ears with her hands. And immediately after Lisa covers her ears, she's destimulating that auditory senses. So this is an example of kind of a sensory stimulation. Internally, she's feeling overwhelmed, perhaps with the sounds at the church. And so covering her ears helps her to minimize that feeling. And so that's her way of compensating and healing herself from that. So we understand, we've identified our unhelpful behavior. We understand why it might be happening. And now we want to look at how we can help to introduce some type of alternative to substitute that behavior. And the two approaches I'm highlighting here are proactive strategies and then directly teaching strategies. And the proactive strategies are really about anticipating, you've spent time, you're trying to anticipate a potential difficult moment and you've planned something in advance. So that could be providing reminders or prompts to an individual, practicing your teaching strategy in a calm time, using social stories, and social stories are a great way that can be made by anybody to really help to prepare for challenging situations that might come up. And you can also proactively change that individual's experience in that environment. So one example in regards to kind of this automatic sensory stimulation is with the, I've changed the name here, but Sakai walks into church with her mother. Sakai covers her ears with her hands, the destimulating senses, okay? So we can change the environment by giving Sakai some noise canceling headphones. So in this example, Sakai walks into church as the behavior, but Sakai is also given noise canceling headphones. So this time, instead of whining, the behavior that Sakai exhibits is she walks into church and sits down. And the consequence of what happens immediately after is that Sakai also gets to kind of participate in the church environment and what's happening in church, gets praise from her mother, but because she also has the noise canceling headphones, she's still able to manage the auditory input. And now we'll get into teaching strategies. And so we talked about the functions of behavior being attention, access to a toy or an activity, escape or avoidance of a task, and then that automatic sensory stimulation. For these first three, attention, access, and escape, one great way to start is teaching some type of communication. It's a way to help introduce an alternative behavior for those. For the sensory stimulation, ways a particular teaching strategy is to introduce a new sensory experience that tries to fulfill as much as possible in the exact same way that need that individual's expressing in their sensory experience that might be unhelpful. So I have this table here for examples of some teaching strategies for replacing an unhelpful behavior. So if we have attention, Alice is screaming and shouting in short red. Maybe we can teach Alice to request for attention. That could be a sign, that could be a picture, it could be a gesture, but teaching me that skill to request for attention can substitute a screaming, shouting behavior. Another example here is escape. The teacher came, put a book on the table, and I didn't want to read the book, so I put my head down. Maybe I could be taught to ask for a break. Again, this could be using gestures or signs or pictorial or visual types of cues. Another tool that can be used here are visible schedules that can show this is the time for reading books, this is the time for your play, and getting that practice in. A sensory stimulation example, we have here example of, somebody who may chew toys and objects to a lot that, everything goes into their mouth, they can get sick as well. So is there an alternative sensory experience that can support that oral sensation that they're going after? And so exploring types of chew toys or something that can be chewed in a way that can also stay clean. And so being able to teach that sensory experience through practice. So part of the teaching strategies is introducing some type of alternative helpful behavior, but then also having a plan of action for when that unhelpful behavior occurs. And in the same example we had for, screaming at the ShopRite, and I am taught how to request for attention. I can then when that unhelpful behavior actually occurs, there can be a prompt or a cue to guide me to request or to do that teaching behavior in an appropriate way. And for prompting or cueing, there's various stages that you work through depending on where that individual is at. From a physical prompt to somebody physically holding my hand, tapping my mother to get my mother's attention instead of screaming, to maybe a picture sign, to maybe just a tap, to maybe even just a look or a presentation of some type of pictorial card that's cues for the tap on the shoulder. So prompting can be a very helpful strategy for when an unhelpful behavior occurs that matches with what you're teaching that behavior, what alternative behavior you're teaching. So prompting that replacement behavior. And then the last step was kind of creating that plan for action. So making sure you have a clear plan for the what, who, how, and when. So in that example we had of the sensory stimulation, when Sakai goes to church, her mother will give her headphones and Sakai will put the headphones on. When Temba screams for the toy, his sister will guide his hand to sign my turn, and then his sister will give Temba the toy. These processes, this plan ideally shared across all family members, different settings that the child is in, because then that gives you more time to practice the replacement and helpful replacement behavior that you have actually put in place. It can take time to figure out what is the best replacement, what is the best kind of replacement behavior, but that time does become well spent in the end. But there can be quite a lot of trial and error. So the last thing I want to highlight are really the relationship-based intervention strategies, because I think it's important to combine these with behavioral approaches as well. And the key things we look at in relationship-based strategies are really those that follows the child's lead, meets the child where they're at, and it has a really big focus on interaction and connection, using the natural environment and play-based. And there are examples of interventions here that I've listed below that we can share more about later. The nice thing about relationship-based strategies is that they aim to really target kind of like foundational skills such as interest in the world, engagement, and joint attention, which we know are so important for building social communication and cognitive skill development in all children. And so being able to practice these in play-based ways where the child leads the engagement can be helpful. So in closing, strategies for enhancing social emotional development and really integrate family support, behavioral approaches, and that relationship connection interventions, as well as looking at sensory processing and communication. I know Jessica will kind of dive deeper into those, but really taking the sensory processing into account when we're thinking about unhelpful behavior and why or how it's exhibiting. And then really being flexible and really, at the end of the day, really being curious to ask yourself what is underneath this behavior, why could it be occurring before reacting. Thank you.
Thank you so much, Alice. That was so informing. I've learned something today. There's no bad or good behavior. There's just unhelpful and helpful behavior. Thank you so much for that highlight. So we'll move on next to Jessica. Jessica, thank you so much for being available to share this afternoon and evening. Could you please introduce yourself?
Sounds great. I'm going to go ahead and introduce myself quickly so you get to meet my face, but then I'll probably turn my camera off just because I'm having issues with connection today. I want to first say thank you to Dr. Nkole and to Alice for your fantastic evidence-based information that we've shared today. I think we've done a good job about talking about, maybe the medical model of disability when we think about autism, but then also the very practical parts and thinking about how we actually do life now with a child that has autism or an adult that has autism. And so kind of where my focus will be in our quick 20 minutes, it will be a really quick and fast discussion about specifically on communication, how we can really practically help our kids on the spectrum with this, but also using that relationship-based model like Alice has shared with us. So my name is Jessica Mwanza. I'm a certified speech language pathologist. I work here in Zambia, have lived here for the past 5.5 years, and I work at Special Hope Network, which is a parent training program that is around Lusaka. So I'm really excited to share with you all today about just some of the practical strategies we do in our interventions when we're helping kids with autism in our centers. So let's go ahead and get started. So when we think about kind of our learning objectives that I'm going to walk you through, is that the first thing, and we've hinted on it so far in this presentation, is talking about sensory stimulation, okay? And specifically, we're going to talk about sensory processing. And that really leads us into how we understand our child and we empathize with them, which allows us to know how can I best support my child's communication. Alice pointed out that 3 of the 4 functions of behavior have to be treated with communication. And so we're going to start talking about that. We're going to understand what stage or style my child currently is in, and some practical strategies of how I can help along those stages. Understanding sensory processing is going to help us understand how my child learns. And then very briefly at the end, I'll point you to some resources that you can look up on your own time about how to teach my child, as well as learning from autistic voices. I think it's really helpful as a practitioner that works with these kids day in, day out, is to understand their voice and their perspective. And so there's some people I'd like to share with you that could really help you as a parent, or if you're a practitioner that's working with kids with autism, it can help you understand and empathize with their perspective as well. So sensory processing, what is it? The technical definition of what we're thinking about sensory processing is how the brain receives, interprets, and responds to signals received from inside the body and stimulus outside the body, okay? Another word that you might find in the literature is sensory integration. Basically, what this means is how my brain interacts with my environment and then also inside of myself. And believe it or not, most of us were taught there are only 5 senses when we were in elementary school, but there are actually 8 in total. These 8 senses are proprioception, sight, hearing, touch, smell, taste, the ones we've probably heard about before, right? But proprioception are balance, and interoception are ones most people aren't as familiar with. And so when we think about interoception is that feeling inside of my body. So you remember how Alice mentioned earlier, feeling a scratchy itch, or maybe you're feeling hungry, maybe you're feeling sick. That is interoception, understanding my internal body signals. When we think about balance, that comes from our vestibular cochlear system inside of our ears. There's fluid in there that helps us keep our balance. But then proprioception is my brain's awareness of my entire body, not just each of these senses individually, but how these all work together in space and in time to help me achieve the things that I want to do every single day. And so when we think about kids with autism, you've heard this word thrown around, sensory. But like, why does this matter for our kids with autism? So again, when we take that neurodivergent perspective, as Alice was sharing with us earlier, we believe that the brain is wired differently in our kids with autism than somebody that we might call neurotypical. And when we think about sensory processing, it's not uniquely an autism characteristic. So actually 80% of other children with developmental disabilities. That could be cerebral palsy, Down syndrome, global developmental delay, hydrocephalus, the list goes on. 80% of children that have a developmental disability also have difficulties with sensory processing, because it all goes down to how that brain receives and sends information. And this is important because when we think about development holistically, especially if we're thinking about maybe the nature and nurture perspective, is that children and adults learn from our environment. We learn through physical experiences. So basically, how my body interacts with other people allows me to learn and grow in different ways. And so when we're thinking about our kiddos that have autism, it's important us to consider these things, because I'm going to interpret information different than you and I, which then impacts the way I develop. So one illustration that I like to give is like you're planting seeds in the garden, right? Maybe I have 2 seeds, I put them in the ground. Nature will tell me this seed is a maize seed and this seed is a butternut seed. But as these things grow, I need different things to help me become a mature maize plant and a mature butternut plant. I might need different water, I might need different sunlight. In the same way, our kids have different sensory needs that help them with their behavior of feeling calm and my mind being ready to learn and not being triggered emotionally by anxiety about things that are happening around me. But it also helps me gain information from my environment when those are taken care of. Another analogy that I like to also give, because sometimes people are like, I'm still confused, I don't understand sensory processing, is that I want you to think about it like a row of cups. Imagine you're holding a tray, and on that tray, you have all 8 cups that are holding all of your sensory information. This one over here is holding your sight, this one's holding your balance, this one your touch, your smell, all of the senses are there. If we all lived in a perfect world, all of these, but in reality, it's not actually like that, okay? And it's not just that for our kids with autism, it's even for us as adults, is that our cups are all different sizes. Some are small, some are big, some are like kind of halfway tilted over and tend to leak more than others. And some are so big that it's really hard to meet our needs, even though we're trying. And so I like to give this personal example of myself. As a speech language pathologist, I do a lot of feeding and swallowing assessments where I'm watching children eat and diagnosing their muscles. I can use my sense of sight all day long to watch them, and I might not be triggered by that sensation where I get an uncomfortable feeling in my body. But my hearing, on the other hand, I'm very sensitive. So if I hear somebody chewing in a restaurant, that's going to make me feel much more upset than if I'm visually watching someone. So you can probably think of yourselves as well of which things maybe you can think of them perhaps as your pet peeves, but most likely it comes from your body's sensory processing of your environment around you and how that helps you learn and interact with other people. And so sensory processing is different for everyone. If we're an adult, if we're a child, if we have autism, if we don't have autism, we all have different size cups. And how I process my sensory information helps me become a better learner. However, sometimes how I process information can become a barrier. So it can turn into some of those unhelpful behaviors like Alice mentioned, because my body isn't able to learn in the same way that somebody else who has autism or doesn't have autism learns. And so it's really critical for us to think about what are my child's sensory processing baseline, their preferences, like how do they interpret these things? Because that's going to impact how I grow in my communication, how I grow in my social emotional skills, my motor skills, everything kind of hinges on how I'm able to accommodate for those sensory processing needs. Okay, so it's important for us to understand ourselves as family members, parents, caregivers, practitioners, but as well as being very mindful about our individual child as well. So I really love the example that Alice gave in thinking about our friend as she was going to church, and how for her to be successful in communicating and participating in her daily life, being able to have that sound blocking really helped improve her ability to learn from others. So if you'd like to learn more about the different sensory profile types, I would recommend you to look up Winnie Dunn's work. She's an occupational therapist. Typically, the assessment and diagnosis of sensory processing will fall on an occupational therapist to determine which profile your child kind of falls in. For the sake of time, I don't have time to explain each of these, but as a parent or as a therapist or as an educator, it's really important for us to understand the sensory profile of our child, because that tells us how we're going to teach them. So let's go ahead and talk into the communication a bit more. So when we're thinking about our children's communication styles, I want you to first think about how communication even develops in the first place. Okay, communication is developed by interacting with people during social interactions. We do not develop communication through TV, videos, computer games, YouTube apps. No. Research shows the more screen time we give kids, actually it decreases the language development. So when we're thinking about communication, we have to know how does my child learn? How, if I have autism or don't have autism, how do our kids learn? They learn first by listening to others. I don't know if you've worked with a kid that is really good at listening to you when you don't understand or you don't think they're listening, because they'll repeat back what you said later on. Kids really listen to a lot of what we say. Kids explore with their own mouths. That's when kids are babbling and they sound like they're speaking a different language, or they're speaking like aliens because they're trying out words to see if that works. A lot of our kids with autism use echolalia as a learning strategy. And it's actually typical until kids are 2.5, 3 years old. And so I repeat what other people say to help me learn. I might script, which means I copy whole words or phrases to help me learn how to communicate with other people. I might use my body language by pointing. I might slump my shoulders. I also might do gestures where I act out an action. If I want to go run, I might move my arms up and down. I also use my facial expressions. Some kids are really expressive, some maybe a bit more subtle, but I tell you how I'm feeling by how I look or my smile, the crinkles on my forehead, those kind of things. But then also, we've talked about stimming behaviors earlier, those repetitive movements that Dr. Nkole told us about. Those body movements are also communication. If I'm feeling overwhelmed and stressed out, I might engage in some body rocking, some hand clapping, or squeezing myself to try to help my body calm, which all is a way that our children practice communicating, both understanding and expressing themselves to us. And so when we think about the different types of communicators, Dr. Sussman from the Hayden Center has written a really great parent-centered training program. It's called More Than Words. I really encourage you to go on their website, www.haydencenter.org, to learn more about this More Than Words approach, because how she categorizes the language development of our kids with autism is very clear and helps us understand what we need to teach at what stage. And so when we think about our communicators, the first stage that we see is our own agenda kids. And these kiddos typically prefer to play alone. They might have limited interest in other people, and they're not quite yet understanding that they need to send a communication and any of those types we've already talked about for other people to respond to them. That's what they have to learn, is that they need to learn how I send my signals, how it's received by somebody else, and how they send them to me equals communication. For our requester stage, these are our kiddos that start they have that concept down. They know my action means something's gonna change around me. So you'll see these kiddos are often the hand pullers that pull your hand, maybe to the fridge to have you open it. They're the ones that point with your finger, not their own finger, to tell you what they want. And they're really great at interacting briefly with people, using a couple sounds, and they really want you helping them get what they need. The third stage is what we call early communicators. And these kiddos move past just asking for things they want. The main difference is the requester only gets you when they need something. Any other time, they're not really interested in communicating with you. Versus our early communicator looks at more different functions of communication. So I'm not just asking you to get things that I want. I also want to share with you about my day. I want you to know about what I'm feeling and I'm experiencing. I want you to enjoy and have that good joint attention with this activity with me. And so sometimes these early communicators, they can do some simple yes, no questions, and they can tell you yes or no. They might be able to do a few WH questions like who, what, where. They might be like, where's daddy? Something like that. And they're really starting to understand the back and forth nature of communication. And then when we look at our final stage, this is our partner stage. And these kiddos, we pretty reliably know they can make some sentences, they can really interact with many people in different situations, but they still might need a little bit help, maybe with their grammar, maybe with their pronunciation, but they're pretty good language users when we think about it. So if you're a parent out there listening, what type of communicator is your child? Which one do you think sounds most like your kiddo? So one other thing I want to just mention quickly before we move into the what do I do now? What do I do to help encourage communication with my child is also talking about a language type. And the Gestalt or Gestalt, there's two different pronunciations out there, is actually a large majority of our kids with autism have this type of language learning profile compared to what we would say is the typical development. Typical development means that you learn one word at a time and you gradually move from one-word sentences to two-word sentences to three-word sentences at a very linear pace. However, when we think about our autistic population, they actually use what's called Gestalt language learning, which means I learn in a big chunk, not tiny segmented pieces. So your child might be a Gestalt language learner if they use scripts. I see it very often in young kids, even as young as 2 and 3, who will come in and they can recite to me A through Z, 1 to 10. They can say all their names and their colors and their shapes, but they can't say, hi, Miss Jessica, how are you? That's how I know you're probably a Gestalt learner. Oftentimes they might refer to themselves in the third person instead of using a pronoun like I or me. They really enjoy replaying parts of songs. So I've seen kids like on the phone where they only like to listen to a certain chunk. And they also have consistent phrases that they use over multiple experiences. And so, for example, there's an instance with one of my clients who he had learned a phrase, the green apple, to communicate the word no. So it's a bit confusing, right? The green apple doesn't really sound like he means no, but for him, he had learned that consistent phrase and he could use it across different situations with different people to try to communicate what he meant by no. We do see some delays in language learning with our Gestalt processors just because they're learning in the big chunk. They're not learning in the smaller chunk, but they often have a very lively, animated kind of tone where it almost sounds like sing-song. There's that musical part to their voice that they're communicating. And so when I want you to really take away about language development, it's particularly for our autistic population, it does not go in a straight line. It does not go linear like what we see in the developmental checklist. Kids with autism, I like to say, have popcorn skills where things might pop up at different times in their life, but it always shows us that they have the capacity to learn. I might not learn the same way as everybody else, but I can learn and I can learn to communicate with you. So quickly, we've got about 3 minutes left. Let's talk about what do I do? Number one thing, like Alice was saying, and I will repeat this again, be an observer. Always observe and try to figure out how is my child already communicating with me? Is he a body gesture kiddo? Is he a vocal words kiddo? Maybe he likes to use picture communication. Another word is AAC to communicate with me. Follow your child's lead. Play with the things they want to play with. Do the things that they like to do. Because when we actually pressure kids to talk, when we say this, do this, it actually decreases the likelihood of them communicating. Use day-to-day routines. Routines are the best because they're predictable, they happen multiple times, and have lots of repetitions for your child to be able to participate and say. So maybe he gets to pick out the shirt he wears when he's getting ready for school, or maybe the tie. Always respect all communication attempts. So if your child is trying to say a word and maybe they're not saying it perfectly, don't harp on them about saying it incorrectly. Instead, just show them how to say it the right way. Also, teach the next step. One of the links that I have for you at the end of this presentation is called task analysis. And I would encourage you to look through it. Is that sometimes when we think about communication, there's actually 8 steps it takes to do one thing. So you might want to break down, if there's a communication situation where your child has a hard time talking, break it down into small steps to figure out which one am I actually having troubles with along the way. And then also, especially for our Gestalt language learners, model it from the child's perspective. A lot of times we ask a lot of questions, but we never show them how to make a sentence. So instead of asking them, how are you, a bunch of times, expecting them to say fine, model the whole sentence. I'm fine, or maybe I'm sad. Don't tell them they're fine if they're being grumpy. Model something that's appropriate. But then also, like Alice mentioned, really emphasize multimodal communication. For some autistic individuals, voicing can actually physically be painful, so they prefer nonverbal ways of communicating. So try out some sign language, try out picture communication, try out picture books. One really great free app is called Sounding Board, and you can get it free on iOS or in the Google Play Store. But you can put pictures in there, you can program exactly what you need for your family, and your child can use that as a communication method with you. I'm going to skip these ones for now, but kind of what I just want to end with sharing is pay very close attention to understanding how your child learns, because that's the key to communication. That's the key to educational development, is that if we don't take time to be an observer of our children and learn their interests, personality, curiosity, their sensory processing needs, we're fighting a losing battle. It's so important for us to first be an observer, understand my unique child's needs, and then I can start teaching them. This is one of my favorite quotes. I'll forever share it again. But if a child cannot learn the way I am teaching, maybe I should teach in the way my child learns. Also, if you are an Instagram person, go learn from some autistic voices. These are just a few examples of folks. I'm seeing now that their names kind of got mixed, but the first 3 people are actually diagnosed with autism. Courtney is in the wheelchair. Evie is the gal in the blue shirt. She is from Canada. And then the gal holding the elephant is from the States, but she is deaf, autistic, and is an occupational therapist. So she really shares a great perspective about being a professional that helps people work through the things that she's worked through in her own life. And the very far end is Jessie Ginsburg, and she is called the Sensory SLP. I really love her content. She has free parent trainings about sensory processing on her website. So I would encourage you, go there. It's free. You can learn more about sensory processing. But she really takes that neurodivergent approach and how we can elicit communication. And she has a great YouTube channel that talks through more about what you can actually do as a parent and a practitioner with our kids with autism. So hope that gives you guys some homework, some things that you can go and look up. But it's been really great to spend time with you guys today. And we look forward to answering some of your questions next.
Thank you so much, Jessica. What you have just presented is a tall order. Already we failed to communicate with some of our kids, and now we have to learn to observe and learn to see what our kids find out how they learn. I think those are some important things that I've picked up from the discussion. Thank you very much, Jessica. This has been a great term, and ZPA is highly indebted to your availability for this important session. We appreciate your partnership with us, and we will call again for anything as we continue to advocate for the child's care in Zambia. Thank you very much. Thank you all that have joined in this afternoon, evening. We appreciate. We do hope you've picked out something. I know some questions we've not responded to them, but I hope you can reach out through the various platforms and forums that have been shared. So that being said, thank you, Jessica. Thank you, Alice. And thank you, Kafula, for your availability. Do have a blessed evening. Bye-bye.